Welcome to the ACS Brief from the Frontline Surgeons' Voices. With me today is Dr. Joe Sharma. Dr. Sharma is the Vice Chair of Quality, Patient Safety, and Innovation and the McGarity Chair in Endocrine Surgery at Emory University. In addition, he is the Chair of the Board of Governors Telehealth Workgroup. Welcome, Dr. Sharma.
Thank you, Dr. Wexner.
It's great having you here addressing a very hot current topic, which I think really came to mind during COVID. So perhaps we might start there. What got the Board of Governors Telehealth Workgroup working?
Thanks for that question. I think it's really pertinent, when we look at the legacy the Board of Governors has in evaluating the electronic health record and kind of the digital formats that we have in medicine. We were always thinking about telemedicine, but the pandemic forced us to look at this aspect of delivery of care much more, cohesively. And we felt like there needed to be a work group that would look at its incorporation, the innovation that we needed in 2020, particularly with the pandemic, and also how we could maintain the issues that we've always had with medicine, which are, looking at diversity issues, looking at making sure the patient is patient-centered, equity, and access. And so we felt like it was broad enough of a topic that it would require its own work group. And we were lucky enough that we have a very energized work group who wants to make sure that telemedicine remains part of patient access and patient care coming out of the pandemic.
It's interesting when you speak of access and equity and telehealth, because clearly there's some big differences in electronic literacy, for example. Certain groups that won't necessarily be able to communicate in a video, maybe even have difficulty potentially with telephonic communication. And those issues are perhaps amplified as we look at our international governors, where we have people representing chapters and surgeons and therefore patients from all over the world. And are those issues being explored as well, how to bring more people along?
I think so. I think the geographical aspect is something that we have paid attention to significantly. International governors are part of the work group, and they definitely bring a different concept, and kind of their need was actually, I would say, greater than even the need that we sometimes feel as US governors. And their adoption of this technology was much more rapid, and their use, I would say, is broader, and we actually have a lot to learn from the experiences of the world. And one of the vignettes that we are working on for the ACS bulletin is specifically looking at geographical issues. Now, obviously, with any technology, there are going to be some groups that are helped more. And when we specifically talk about digital literacy, I think there is a need for making sure that we have a pathway for that patient population that may not be as literate, or that provider that may not be as literate with anything digital.
Okay, I think those issues have been highlighted in a lot of publications, and came up during COVID, certainly, that not everybody had access when there was remote learning, for example, for kids, and the same issue is at play here. But let's talk about another area, which is the active projects underway by the Board of Governors Telehealth Workgroup. Maybe you can clue us in as to what's happening.
I think we realized very early on that the topic is huge. We have advocacy issues, we have legal reimbursement, geographical issues. So we started with what we felt like was an appropriate place of looking at how and characterizing how telemedicine was used pre-pandemic and during the pandemic. So looking at inpatient settings, so we have a great example of the EICU, and we're looking at the geographical location issues, looking at particular disease types that were more likely to be managed on telehealth versus, vascular surgery with their vascular ultrasound and the need for some of those testing. How do you incorporate that with telemedicine? So our first goal was to get those vignettes out. We started in 2021, and in 22, there'll be more in the ACS bulletin. The ultimate goal was, however, to produce a 25 to 30 page primer for taking all these considerations and having essentially a checklist way of incorporating telehealth into surgical care. And that's something that we're hoping to deliver at the later part of this year.
That's great. Are there other educational initiatives being undertaken by the work group?
I think that we obviously will educate based on others' experiences. We would like to also bring in the elements of quality and patient safety. And so at the Quality and Safety Conference, we will be talking a lot about what are the quality metrics that can be delivered perhaps better with telemedicine than we could with in-person visits, and how we have improved patient access, and what are the pitfalls. So we're going to look at it from almost every angle. Some are probably more prioritized, which is incorporation of it, but quality and patient safety is strong on our minds right now.
The group that you have convened obviously is by definition governors. Are residents and fellows being incorporated, medical students, as you look at some of these issues? Because certainly they are the future of whatever happens with telehealth.
There's a lot of expertise at the college beside the governors. We have the IT committee that's been working in this area, and there have actually been past presidents of the American Telehealth Association that are members of the college. The resident group, the RAS Society, that we have 2 representative members from them that are specifically examining this from an academic standpoint, so we can actually have some publications that look at some of the issues like access, but also how their education will perhaps change. We already know it's changed in the last 2 years with the pandemic, and what will be the effects of that. And then last but not least is the advocacy arm, not just of the Board of Governors, but the entire college, because there are significant billing and reimbursement issues that exist with telehealth. So we are lucky in the Board of Governors that we have all this help in this work group.
That sounds like an amazing group of people. I'm sure a lot of good things are going to come out of the group. Last question for you, if you could sort of dust off your crystal ball, where do you see telehealth going in the next 5 to 10 years? Do you imagine it's something that's going to be in every practice, or do you think it's going to be more limited as we get further from COVID?
I think we've already seen what it looks like in the post-pandemic time period. So the Michigan group, the Blue Cross Blue Shield data that came out of about 4,000 practitioners, that there was a huge crescendo up, and then there was it came down rapidly out of telehealth, but it came to about 20 to 25% of surgical volume of patients were being examined through telehealth, even in the 21 time period. I think patients are demanding it. We have had numerous requests. I have a lot of patients that come in for 5 or 10-minute visits that have a bunch of radiology labs for chronic cancer care. Those patients are asking, why can we not have this visit over telehealth when we have all the information that we're going to need? I think for the new patient visits, that's where we need to figure it out better. But for chronic care, I think our providers are, liking it also, because it gives them the flexibility and a clinic flow that's much more efficient at times. So my crystal ball it's here to stay. I just don't know which service lines are going to be the early adopters and which ones are going to be the late adopters in this innovation curve.
Well, thanks very much for your time today. Thanks and congratulations for all you're doing for the college and therefore the fellows members and of course our patients.
Appreciate it, Dr. Wexner. Thanks for the opportunity to talk about this subject.